Good afternoon, everyone, and welcome to our webinar this afternoon. This is a webinar for Black men, epilepsy, and stigma. And my name is Ndubisi Anyalichi. I'm the Public Health Communications Manager for Epilepsy Foundation. This afternoon, we'll be having 4 speakers during the course of this webinar. And feel free to put your questions in the chat. We will have a Q&A session at the end of this webinar. So we will also have time to answer your questions as time permits. I see people are already joining us, and if you could take time to just share your name, your organization, and that will be a good way for us to, begin the conversation.
Hello, I'll start off. My name is Dr. Sean Smart. I am a neurologist. Specifically, I'm an epileptologist, meaning I specialize in epilepsy. I am an associate professor at University of Texas at McGovern Med School in Houston, Texas, where I am the director of inpatient neurology, as well as the vice chair for quality improvement.
Thank you. Anyone else want to share?
I can go. Hi, my name is Dr. Vishon Broadnax. I work at Howard University in the School of Business. I'm one of the advisors in career and academic advising, and excited to be here.
Thank you, Doctor. Thank you, Broadnax. Thank you.
Hello, my name is Lowell Evans. I'm the regional director for the Epilepsy Foundation of Virginia, and I'm located here in Hampton Roads. I'm happy to be here.
Thank you, Lowell Evans.
Good afternoon, everyone. Glenn Lloyd from the Epilepsy Foundation of Minnesota. I serve as the Chief Executive Officer and Executive Director of our public health affiliate here, based out of Mankato, Minnesota. Really looking forward to a great discussion today.
Thank you, Dr. Glenn. Okay, we are about 3 o'clock now, and I will just go ahead and begin our webinar. Like I said, welcome again to the Black Men, Epilepsy and Stigma webinar. My name is Ndubisi Anyalichi. I'm the Public Health Communications Manager for Epilepsy Foundation. This webinar is supported by, before I get into the thickness of our webinar, I would like to read out our session format so that every participant, more like our ground rules. So all participants are muted, and please remain on mute unless you're instructed otherwise. Type your questions into the Q&A sessions, like I said earlier. We would have time to answer your questions in the course of the webinar. Type your comments in the chat box, and this meeting is being recorded. Please, if you're joining us after now, provide your name, organization, and geographic location in the chat box. So the mission of Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizure and find cures and save lives. So this webinar is in partnership or supported as part of Epilepsy Foundation's cooperative agreement with the Centers for Disease Control and Prevention. The content in this webinar does not reflect the official views of the CDC. There is one free continuing education unit that's been offered for certified health education specialist for this webinar. Please be sure to complete the survey at the end of this webinar and provide your CHES or MCHES number. Today's webinar is part of the Foundation Multicultural and Health Equity Program, activities to raise awareness and epilepsy disparities among African Americans and in observance of Black History Month. Next slide, please. So our session objective is to, one, define epilepsy and health disparities among men living with epilepsy, identify unique barriers to care and social determinants of epilepsy, including stigma impacting Black men with living with epilepsy, discuss appropriate and effective methods to communicate health messaging to Black men. So here we are talking about stigma and epilepsy, and it's important for us as African Americans to understand that stigma is one of the common features that can cause serious harm, to our physical, mental, and social well-being in general. And if you look at it from an African American perspective, you begin to see why it's important for us to actually come up with, having this conversation.
Can you put the music a bit softer? Yeah. Can you?
I'll just do it. Anika, could you mind put everybody on mute? Yeah, so there are over 25,000 African Americans with seizure diagnosed each year. And African Americans are more likely to be diagnosed with epilepsy than Caucasians. Stigma and access to appropriate care have been identified as major concern for many African Americans. Next slide.
Thank you.
So here again, we further define stigma as either enacted stigma or felt stigma. For enacted stigma, this refers to a period of discrimination by the public against people with epilepsy, while for felt stigma, this refers to the embarrassment associated with being a person with epilepsy and the fear of enacted stigma. I would like to share here that the foundation is currently we've embarked on a anti-stigma campaign about epilepsy. And this information that I just shared are insights that we gathered, while we prepared to launch the anti-stigma campaign. So it's more than necessary for us now to even have this conversation in a more broader environment like this one. Next slide. So I would like to introduce our first speaker of today. His name is Dr. Sean Smart. He attended the University of Miami, where he received his undergraduate degree in biomedical engineering, physics, and philosophy, while also being part of the University of Miami Honors College. He received his medical degree from the University of Michigan Medical School and completed his residency in neurology at the University of South Florida. Dr. Smart is currently an assistant professor in the Department of Neurology at the McGovern Medical School at the University of Texas Health, Houston. Please join me in welcoming Dr. Sean Smart as he opens the ground for us in this wonderful discussion.
Hello, everyone. So as I said before, I'm also an epileptologist. I did my fellowship in epilepsy at Duke University. So the first question that everybody has to understand is, what is a seizure? Now, a seizure is interesting because everybody thinks of the brain always working together, but that's not actually completely true. You have to think of the brain, the simplest way I can explain it to, as a computer, where each part of the brain needs to be doing something different in order for everything to work. Well, a seizure is when too much of the brain is doing the same thing at the same frequency. Now, the interesting aspect of it is everybody thinks of seizures as what they can see, which is the motor aspect, when people are moving, either their whole body shaking or part of their body shaking. But that is actually the smallest subset of seizures. The most common seizures actually cause alternation in awareness and consciousness, because the most common location for seizures is actually the temporal lobe, which controls our memory and our ability to speak, depending on which temporal lobe we're talking about, while the motor aspect is in our frontal lobe. So that's the first thing. So think of seizures as like an electrical storm in the brain that literally takes over control of the brain. And think of seizures as the part of the brain working too much in sync rather than doing their each job. The way I explain it to students sometimes is, think if you have somebody's in a factory, right? And you have the assembly line, and everybody's supposed to be doing their job on the assembly line, but then some people decide to get together and start dancing together in unison. That's kind of, the whole assembly line gets shut down because they're all working together doing something they're not supposed to. And then epilepsy is the propensity to have seizures. So the formal definition is greater than a 60% chance of having a recurrent seizure. Now, that typically comes down to if you have 2 or more seizures unprovoked, meaning something didn't directly cause it, in greater than a 24-hour period, or if you have damage to your brain or abnormalities on an EEG. And if you have epilepsy, that is when we begin to consider using medication. Everybody gets 1 free seizure before we stick them on medication, unless their EEG is significantly bad. Next slide. What we're seeing recently is that epilepsy is a worldwide phenomenon. We have a tremendous amount of the population, and actually one of the largest population we've seen in a while with epilepsy, with over 3.4 million people in the US and rising with the diagnosis of epilepsy. What we do know is there are certain things that increases your risk of epilepsy, such as in younger patients, we have infections in the brain, trauma, as well as, and in older individuals, we have such things as cancer or strokes that increase our risk of seizures. So as people are living longer and surviving more strokes and cancers, we're seeing also a rise in epilepsy, but also as we see more people surviving traumatic brain injuries, and also some of the sports that we play, as we see more concussions, we are also seeing a rise in epilepsy, because yes, a significant concussion can increase your risk of epilepsy. Next slide. What we also are noticing is that approximately 40% of the 3.4 million people with epilepsy in the United States, and we do see some disparities in the people who are getting epilepsy. We know that males in general, regardless of race, have a higher rate of epilepsy than females. And we do see a higher rate in African Americans. We don't exactly know why. Some of this is believed that in general, when you look at males, they're more likely to get into issues with traumatic brain injuries and or alcohol use and other things that may increase your risk of epilepsy. And as well as we see men and everybody living longer, we see a greater effect. Now, the question is, how do we manage people with epilepsy? Because epilepsy, one of the issues that comes into when you talk about the stigma and those things with epilepsy is, how do people live with epilepsy? Now, what makes it hard for some of my patients, especially men, and especially African-American men, is epilepsy is the condition where your body takes control of itself. And this is what makes it hard, because you never know when all of a sudden you're going to lose control of yourself. So what I found is it can be very distraughting, very depressing, because of the fact that your body literally starts moving by itself, or you start not being able to speak or do things that you usually do easily. And that can have a significant effect on somebody's mental state. And then on top of it, once we start treatment, there are always some concern about the effect that medication will have on a person's sexual functions. And that's something we can work with. We're usually able to work with the individuals and find the drugs that are not having any significant effect or lessen the effect. Next slide. Now, what we do see, unfortunately, and this is, unfortunately due to the socioeconomic as well as the general stigma that we see with epilepsy, is typically men, African-American men, are more likely to be diagnosed in the emergency room rather than necessarily in a doctor's office. And I think this is twofold. I think one, even African-American men of means may not necessarily go to the doctor as often as they should. Number two, there is this, as I said, even amongst doctors, there's this misunderstanding at times of what epilepsy or what seizures are. So it's easier to overlook African-American men who come in with behavioral abnormalities as being behavioral abnormalities rather than necessarily seizures. And I'll give you a perfect example of one of my early cases in my career. I had an 18-year-old gentleman who was playing basketball, got hit in the head, and initially came in diagnosed as a new onset schizophrenia because he had behavioral abnormalities, acting funny, somewhat aggressive at times. Nobody thought about the fact that this guy was in non-convulsive status, meaning he was continually seizing. Now, what makes it interesting was he was talking to you, but he was just confused, and they were having trouble controlling him. Now, the problem is when you have people who, how can I say, perceive that behavior as being common to a certain group, it is harder to see that behavior as being clinical. So fortunately, the mother and the nurse decided to keep the patient until I was on service. And when I saw the patient, I looked at the EEG. It was clear that he was in non-convulsive status. And when we were able to talk to his girlfriend, she was like, oh yeah, he came home, he said he got hit in the head playing basketball, and the night before he was just thrashing in bed, and he woke up this morning and he was just confused the whole morning, which is classic for somebody who has a generalized seizures and then is confused afterwards. So there's an issue with getting the diagnosis correct because of the socioeconomic as well as the social structure inside the US. So the black men tend to find in the emergency room once they've had clear-cut multiple generalized convulsions. And then even after that, unfortunately, we find that they're less likely to actually get care. And some of that is also due to socioeconomics, but also some educational issues in our communities about the advantage of being on anti-seizure medication, right? There is this belief that somehow if you're on anti-seizure medication, that they'll mess you up, they'll cause issues, while we can get you on anti-seizure medication and control you and you function completely normally. Like what I tell some of my patients when they're worried about the long-term effects is there are a lot of CEOs, Supreme Court judges, and people who are epileptic on medications doing well. But that perception of epilepsy and medication slowing down the brain, causing them trouble, is something that is hard to break through. And with the more uncontrollable seizures they have, unfortunately, is why we think there is a increase in sudden unexpected death in epilepsy, such as, we had a basketball player not too long ago, Demarius Thomas here, died suddenly of epilepsy, right? And you would not expect that because he was wealthy, had means, but everybody explained that his behavior was off. But nobody ever thought that he was actually having seizures, probably from the temporal lobe that was affecting his behavior until he died. So those are the things we think we are missing. And as I mentioned before, the increased risk of seizures in the African-American population, as we see an overall rise in epilepsy throughout the community. Next slide. So as I was mentioning before, a lot of this is a lack of access. On top of the discrimination and the stigma that goes along with it, right? Because one, there's not a lot of doctors, there's not a lot of let me back up. There are not a lot of epileptologists in general nationally. Number two, there's definitely not a lot of Black epileptologists. And unfortunately, sometimes when I've met patients, they need somebody who can relate to them to explain to them why they need to take this medication and why it's important for them to take the medication. And a lot of times they're afraid of the stigma or the effect that they'll have, because there are limitations. While I say you can live a normal life, there are certain things you can't do once you're on medication. For example, you can't be a pilot. Everybody thinks that's reasonable, right? And you can't drive like a big rig. I've had one of my actually African-American male patients get mad at me because he decided he was going to drive a big rig. And I had to tell him that is actually the one profession other than a pilot that you can't do. And then he threatened just to come off his medicine. I'm like, well, you still can't do it because we still know that you have epilepsy. So these are the things where sometimes it needs somebody able to have these difficult conversations with them and explain to them what they can't have a normal life within, taking care of themselves. And some of the comorbidities that we concern when it comes to epilepsy is the mental health issues, but also one of my concerns sometimes with African-American males and epilepsy is the comorbidities that we see in the African-American communities in general. For example, we do have a high rate of diabetes, obesity, and hypertension. What I tell people at times, the reason why seizures are so dangerous, think about running a marathon in 30 seconds. That is what a generalized convulsive seizure is. Every muscle, every inch of your body, of your heart is fully active for 30 seconds to a minute. And unfortunately, some people's heart give out. Even people who survive it, sometimes we have to take them in for cardiac catheterization or other procedures on their heart because they end up damaging their heart from the seizures. So these are all the things that I think is not well understood. And hopefully from discussions like this, we can do a better job educating the community so they understand that seizures are not just motor. Seizures can be behavioral and are most likely behavioral. And motor seizures, especially generalized seizures, can be fatal if they're not controlled. Next slide. And one of the concerning thing is, as we see a rise in deaths from epilepsy, and we struggle to try to understand this, but what we do believe is that some of this is due to the overall rise in obesity, hypertension, and other risk factors in the United States in general, not just in the African American communities, and in males throughout the races, especially African American males. And then, we play a violence, we tend to predominate a violent sport. Because as I said before, a grade 3 concussion, meaning being knocked unconscious from head trauma, actually increases your risk of having seizures. Right? So you have people who grow up their lives playing football or soccer or playing rugby or playing or boxing or MMA who takes multiple traumas to the head. And if you've ever been knocked unconscious from any of those, that increases your risk of seizures. Now you combine that as you live your life and you see other morbidities of hypertension, obesity. Well, if you start having seizures, those things become even more important to control because seizures put all of those things at greater risk due to the strain that it puts on your heart. And that would be mine. And if any questions, I'll hang around and I'll hand it over to Glenn. Thank you.
Well, I just want to say thank you so much, Sean, Dr. Smart, for your presentation. I think I'm about to be introduced, but I want to say thank you. I'm fascinated. I wish you were treating folks in Minnesota, and you can come on this way. We'll bring you here. But
you're welcome.
Thank you so much, Dr. Smart. Thank you so much for sharing that wonderful insights on epilepsy. So our next speaker, who has already seemingly introduce himself, is Dr. Glenn Lloyd. He has been the executive director and CEO at the Epilepsy Foundation of Minnesota since March 2020. He is a passionate advocate of all people with epilepsies and seizures disorder. Dr. Glenn has more than a decade of experience in development and program management, both higher education and social services. Glenn graduated from Catawba College in Salisbury, North Carolina, with a Bachelor's of Arts in Communication and Political Science. He's a native of Washington, D.C. region. Again, join me in welcoming Dr. Glenn Lloyd.
Thanks so much for having me, and to not take anybody that's worked hard to get an MD, a DNP, or any other PhD. I am not a doctor, but I did stay at a Holiday Inn a couple of years ago. It's great to be with everyone and to bring perspective to this really important topic about Black men, epilepsy, and stigma. And I want to really frame out and say that the discussion I bring to this is a call to action and an expectation that we get to the business of seeing the issues that are challenging our communities and seeing everyone in our community. As we are at the latter stages of Black History Month, I could not miss the opportunity to elevate James Baldwin and his important encouragement for us as a community to continue to look at our issues, to frame them out, to be passionate about addressing issues as we see them. And it's a reminder that so much of the work that's happening on the medical front with Dr. Smart and his colleagues that plays out in communities every day through public health and community organizations, that we really can't change the environment of people living with epilepsy and seizures if we aren't willing to face that there are challenges and that there are disproportionate challenges in our community. And I really do resonate with this, that not everything that is faced can be changed, but nothing can be changed until it is faced. Next slide. So as we think about our direction as a community, it also requires some reflection. Oftentimes in epilepsy, we have really been galvanizing, and there's a momentum, a sense of public health interest in addressing the challenges, both from a health standpoint and a quality of life. And oftentimes we see our epileptologists, our neurologists, our doctors, general doctors, hospitalists on the front lines of addressing how do we stop seizures. I would argue that we also have a more important call to action, which is to many folks who work in public health. If we cannot do a better job at acknowledging our historic challenges, it is going to be really hard to address the persistence of the current climate and an attempt to change the future. So I want to begin by addressing some epilepsy disparities and inequities so that we can see the scale of our problem. And Dr. Smart addressed some of the real concerns around increased rates of sudden unexpected death in Black men, addressing the fact that treatment often isn't taking place at specialty care clinics and hospitals that are our partners with National Association of Epilepsy Centers. We know that as we think about those who live within our local communities, thinking about who are trusted health partners that can help bridge the gap in lifting people's confidence, and then being able to be a partner, to be a coach, to be a consultant, to be a friend that moves people towards better health and better quality of life is an important aspect of the work taking place. So I issue this call to action. You're here with us today having this discussion. I will tell you that it's taken too long for us to get serious about addressing all of the needs in our community, and particularly in our Black community, knowing that there's a higher percentage of men living with epilepsy, but it doesn't have to be this way. We can look to the other side of the coin and see all of the opportunity to embrace this work and move it forward. Next slide. So, once again, John Lewis, the great John Lewis said, when you see something that's not right, not fair, not just, you have to speak up. You have to say something, you have to do something. And that's what I want to talk about is in these short moments we have, what do we do? What are we seeing play out in our communities at a local level? Oftentimes it is thought that if we can just have one great salvo that can solve all of our problems, if we could just have enough money, man, we could solve every issue. I would argue that we need to focus on prioritizing what we see wrong in our communities and those that have the worst disparities and inequities playing out in their life, that when we see it, we do something about it. Next slide. So the call to action is really specific. I want to talk about the three aspects that I see being critical as we think about Black men, epilepsy, and stigma, which is to elevate the responsibilities of adopting public health best practices around health and wellness and quality of life supports, being able to integrate with community services at the social services level. Listen, there are plenty of social welfare programs that are designed and focused on people living with disabilities, particularly low-income communities where we see a higher rate of uncontrolled seizures that are very much aligned with what Dr. Smart was saying. We can't draw a clear line about why, we just know that it's taking place. And then third, thinking about public policy, both at the federal level and at the state and local level around shifting the broader environment about the resources available to people living with epilepsy. So for example, in Minnesota, we got really serious about looking at the impacts of what our community was living with. And we found that as the CDC report highlighted in 2022, it's more than likely that people living with epilepsy are on Medicaid. And so oftentimes changes in what state Medicaid plans offer, support and fund through their insurance plans will have a disproportionate impact, we hope, positively on people living with epilepsy. In our community in Minnesota, that particularly means communities of color who are disproportionately lower income than their white neighbors, as well as then access to specialty care is lower, that we need to be thinking about the policy mechanisms that elevate and give people the tangible and the intangible supports necessary to move forward. So as you think about public policy, as we did in Minnesota, we started to know that there were real benefits to thinking about stopping seizures and then looking to stop SUDEP. If there was a way that we could give folks access to seizure alert devices to when folks are having a seizure and being able to utilize it at the best times possible, we could decrease the SUDEP risk that is pervasive for people with uncontrolled seizures. We are really excited to see that the FDA has approved a seizure detection device, and we'd like to see more investment in innovations in that space. As the medical community and technology community adopts a strategy, it's important for us then to think about who has access to those resources. For us to think about this sincerely as we talk about Black communities, based around historic and persistent discrimination by our government, as well as the stigma attached to being disabled or having chronic health conditions, these all interconnecting forces ask us to think about where's our public policy doing the most for our community. So we're advocating for Medicaid to pay for seizure detection devices. This is another burden for folks who already are strained economically and then have the social pressures of stigma attached to their journey. If you are looking to make a difference, think about the ways in which public policy can increase access to populations you don't already see. Particularly then also thinking about public policy. I know my colleagues in New England have made some real investments in community health workers. Folks that are from community, being public health workers and connecting people to the resources necessary. Our colleagues out of Chicago are really invested in transportation access and making sure that transportation is low cost and there are options for folks who are impacted by epilepsy and looking to move around their community. This work is taking place at local levels. The truth of the matter is it needs to be more ubiquitous. We need to be very thoughtful about how we move forward. Next slide. Being mindful of our time, here's a couple suggestions in how we started to address and think about our work in disparities as we think about public health, community services, and then public policy. You got to know your local and state population by racial identity. There is no time for color blindness. When we know that Black and brown communities of color are having disparate, worse, negative impacts and outcomes in their healthcare as they battle with epilepsy. This journey is horrible for every person that is on their journey to getting control with their seizures. It is worse for people based around their racial identity. So as you think about a call to action, how do I move forward? I would encourage you to look at your population data, be able to translate that where you have 15% of your population in your state that are Black, apply that same lens to the CDC estimates of who your population is living with epilepsy. What you'll see is a critical mass of folks that would benefit from your attention and your knowledge of their experience. Then invest in listening and learning and doing the research on the racial disparities that play out in your state, in your local community. Sad to say that it is pretty consistent that no matter where you live in the United States, if you're Black in America and Black and male, you are having a worse experience than your white counterparts. We need to be committed to naming the problem. Once we name the problem, then we can get to the business of thinking about our objectives and how will we address this. This is really hard because often these resources are expansive. It happens at really big philanthropic organizations, but lean on colleagues in the work. Go talk to your physicians in your community, get them to a table, take them to lunch. I know that some of my colleagues down in Atlanta are having this strategy of bringing people around a table and talking about the challenges we see. If we can name it, we have a better chance of addressing it. And then finally, increasing our outcome-driven programming to increase seizure control. The name of the game, and I would turn to Dr. Smart here, he knows it better, is seizure control gets people on a track to better health and quality of life. So thinking about your programming, who is your best partner to connect to Black people in your community? You already have people who have come to your doors looking for help. Reach out to them and be clear about the problem you want to address and the objectives. Any one person isn't the objective. Serving a bigger population that are impacted by these disparate and negative challenges is a call to action that we have found in Minnesota to be really galvanizing. Next slide. Thinking about some of the resources that are available to you that you don't have to do the hard work of thinking about, how do I do this? How do I structure curriculum that can be meaningful? I want to encourage you to go on the CDC website, the Centers for Disease Control and Prevention. They've partnered with the Epilepsy Foundation of America for some time now in writing curriculum, helping elevate the thinking around how folks can manage their epilepsy well, focused on 3 key areas around treatment, seizure, and lifestyle management. The more we can start to operationalize, put these as practical tips for folks as they manage their epilepsy, we will have more meaningful discussions that align with best practices, and then being able to link them to folks like Dr. Smart, who can be an advocate. And while we do have a low number of epileptologists and neurologists who are Black men, it does not exempt all neurologists and epileptologists to think about the impacts of racial identity on the journey that their patients are having. Once again, this is a call to action. Don't presume that it's up to Black men to be able to solve all the challenges. The more we can get into this business of taking all of the best thinking, building bigger tables of collaboration, data-driven and evidence-based solutions, the better our populations can be. And I'd argue by doing it at the base level of those with the greatest disparities and inequities will help rise all boats, as the saying goes. And finally, leveraging Black public health leaders in your local community. Where you don't know where to start, I will tell you that the running joke that there are only a couple Black people in Minnesota and that Prince is one of them. I will tell you that for us in Minnesota, we got to the business of looking through our own Rolodex, our LinkedIn, and reaching out sincerely and saying, I need your help. I need to connect with people who are impacted by epilepsy. And I know that by talking with you, community leader or public health leader or a religious leader, you will help connect me to other organizations, community organizations that are addressing health and quality of life. So it's our problem, and it's your problem, that we all can be adopting a mindset of supporting Black men's health. This is a call to action from a public health standpoint. These are some of the ideas of what we've been working on in Minnesota in a short period of time to help frame out our thinking. I think with that, this might be my final slide. Perfect. Thank you so much.
Thank you, Glenn, for your wonderful presentation. Next is Mr. Lowell Evans. He'll be providing us with a lived experience as a Black man living with epilepsy. Mr. Lowell Evans is from a small rural community in Virginia. He was diagnosed with epilepsy in 2000 after experiencing a traumatic head injury while playing basketball. Today, he serves as a regional director for the Epilepsy Foundation of Virginia. He is the author of The Village, in which he created an African-American character named Kevin Bolden to represent epilepsy and raise more awareness of epilepsy disparity. Please join me again in welcoming Mr. Lowell Evans as he shares his experience with us.
Well, good afternoon, everybody. I'm happy to be here today, and just want to share with you that what I've heard already has been great, because epilepsy itself, speaking as a Black man, we truly need the help from all over. Again, as you mentioned, I developed epilepsy from a fall playing basketball in college. And from that fall, I looked around for help. When it first happened, I had no idea what it was. There was nobody around that could really tell me about it. And when it happened, I was in my bed, 3 o'clock in the morning, and people came in. I thought they were police officers, and when they came in to check on me, they were actually EFTs, emergency people. They took me to the hospital and diagnosed me with epilepsy. And when I came back to college the next day, people were saying to me, African American, people, and also people of other races, they was telling me that I should, quit college, that I should, just look for another way to advance in life. And I couldn't believe that I couldn't find any help, especially from my own race. They were not trying to give me any advice to, to find another direction to advance. And the one thing about it, though, I only had one seizure that night. It was a, excuse me, it was a tonic-clonic seizure. And I didn't have another seizure for like 4 years, but still I was labeled. And people not knowing about epilepsy still looked at me as being something weird. The ones that heard about epilepsy didn't really know about it. They had no knowledge of it. They hadn't really experienced people with epilepsy. I asked them about it. Who do they know who had epilepsy? And they really couldn't name anybody. They said, well, I've seen it. And I asked them, could they explain to me what they had seen? And they really couldn't go into detail. And with Dr. Smart being an epileptologist, I hadn't even heard of the term. I hadn't even heard of the term epilepsy, hadn't heard of the term neurologist or anything. And what really bothered me was that, again, nobody wanted to talk about it. So I went on a bit about my business and just wanted to prove to them that I was normal, and especially my own, African-American race, because they were the ones that were really told me, hey, look, don't tell anybody. Don't talk about it. I said, why? I said, I'm fine. They said, yeah, but you had a seizure. You have epilepsy. I said, to me, it was like I had a headache one time and I didn't even realize it because I was asleep at the time. And when I woke up, I felt fine. they were the ones that took me to the hospital and rushed me to the hospital. But I was fine in the ambulance talking to them. So to me, I just went on about my normal activity. Still graduated from college with a BA degree in sociology, and went. Matter of fact, I took on another part-time job while I was in college. So I couldn't really understand it. And being a Black man and them telling me that I couldn't do this or that, we, well, me and the ones that did, that were in my corner, they said, man, you can do it. Just a very few of them though. They said, man, you'll be fine. And that's what I went on to do. But that head trauma was what they kept on talking about, you know. And then somebody said, even my parents, who are 40 years older than me, my mom and dad, when they heard about it and it was explained to them, my dad said, look, don't let anybody cut on you. He said, you never want to go underneath the knife. And that's all I heard. And so I was going to definitely not deal with that. You know, and that scared me. Excuse me, to be honest with you, it was scary. So I definitely pushed that to the side. But again, without having any more seizures till like 4 or 5 years later, I basically let it go. But then later on, when I was about 26, 27 years old, the seizures started coming back. And just like people told me, don't talk about it. You won't get a job. You won't find a girlfriend, or you know, you won't be able to get a fair chance to move on in life. So I kept it kind of quiet. But then to me, it felt like I was wimping out. And I felt I wasn't giving myself a fair chance, because I was always used to winning in life. I was a Black man that was always used to overcoming. And my dad always told my father and mom, they had 9 of us, 9 children. I said, well, if they can raise 9 children, I said, I can get married and raise at least 1 child with a wife. So I fought it, and I had to get on medication. And I went to a primary care doctor. And again, never heard of neurologist. As time went on, I went to a neurologist, but for years, never went to a epileptologist. It wasn't until I guess I was like maybe in my 40s when I heard about epileptologists. That's because, again, no one talked about it. You know, I was told not to talk about it. No one talked to me about it. And I was around everyone. But when I got bold enough, I said, well, I want to write a book about it. I wrote a book called The Village. And it was because no one was listening to me. So when I wrote a book about it, I got invited to the Epilepsy Awareness Day at Disneyland, which is the biggest event for epilepsy there's in the country. Just because me writing that book, I first had a big event at my church. People from all walks of life came, white, Black, young, old, children. I was on TV first. And I said, why are people coming from all over, out of everywhere now, all over the corners of Hampton Roads coming? And they said, I can't believe you did this. I said, what do you mean? They said, man, you talked about it, now you've written a book. I didn't know you write a book. I said, well, y'all wouldn't listen to me. So I said, somewhere, maybe you read about it. And so that was a big, you know, pat on my back for me. And then when I went out to California for the event, I got on over Facebook. And when it went all over Facebook, the Epilepsy Foundation of Virginia, the top person, Dr. Susan Bischoff, she asked me whether I'd be interested in becoming the regional director. And I said, sure, I'd be willing to do that because I could help more people. But really, I was looking at helping a lot more Black people, because even when I went out to California, I was looking to see people of color out there. But I guess I was maybe between 3,000 and 5,000 people. If they say, look for Lowell Evans, he's a black guy, they would have no problem finding me. Maybe it took them maybe like 5-10 minutes to find me, because there's very few people of color out there. And I just could not understand it. I know some people were embarrassed about it. I did have seizures in public, but with me, I had to get right back up. We got to be strong about this thing. We have to stand up and overcome it, because some people are looking for you to fail, looking for you to give up. Dr. Smart was saying, from men these days, it can be embarrassing. But, you know, do you want to give up? Do you want somebody to, you know, hold your hand or whatever, or do you want to move on in life? With me, when I grew up, it was, you know, you help the person next door, you know, whoever it is, black, white, or whatever, because this can happen to anyone. Anyone who has a brain, it can happen to them. You know, so I believe in that village concept, you know, everybody helping one another. And just because I was black, to me, epilepsy didn't matter. I said, I'm gonna help them, and maybe if they look in my eyes instead of looking at the color of my skin, maybe that'll make a difference. Because to me, epilepsy was the key to me to making a difference for me. I had to go on disability, and I turned that around to work in my favor. You know, now I even had more time to reach more people. And now I have some more blacks, more people of color looking at me, because now I have another position, I have another job working. And they said, man, how are you working with epilepsy? You know, are you going to be, you know, telling about it and still working? I don't see how you can work with epilepsy. I said, I don't have it all the time. It's not something that stays with you. You have to understand more about epilepsy. And that was the difference with me. I made it work in my favor. And that's what we have to do. We have to make it help others and go from there. So I want to thank you for your time, and just say, push on, reach out to others, because the Black community need us to help one another. And thank you again.
Thank you so much, Mr. Lowell, for that powerful presentation. Yeah, that's really powerful, sharing that experience or sharing your experience with us. Lastly, for today is our next presenter, who is Dr. Vashon Bronex. He will be providing a family and community-based perspective. Dr. Broadnex is a native of Louisville, Kentucky. He graduated from Western Kentucky University and Ball State University, and currently resides in Stanford, Virginia. Dr. Broadnex is a higher education professional with over a decade of experience, providing oversight and management of career development, career planning, workforce education, and adult learner services in both the public and the private sector of higher education. Again, thank you for joining us, Dr. Broadnex, and welcome to our wonderful conversation.
Thank you. I hope everybody can hear me clearly. So one of the things when I was approached about doing the SIP webinar, I was like, well, you know, I don't have epilepsy or any seizures anymore. And I was kind of nervous because how can I speak about it? Because the last time I had a seizure, I was probably about 6, 7 years old. But quickly reminded me, like, I have a niece. She's 17 years old, still deals with epilepsy, seizures, and has a myriad of issues associated with it. So, you know, I'm speaking from an advocate more so of a person living with it. So therefore, you know, I want to talk about my niece. Since she was born, she had seizures at a young, early age. She was definitely premature. I think she was about 2 months premature birth. And from there, it was just a roller coaster of continuous issues. One of the challenges she faced was, you know, development because of her seizures. Over that time, you know, we kind of, my sister was very on top of it. And fortunate, we talk about Black families not having the resources or having the opportunities to get the necessary resources. I was fortunate. My mother worked in a healthcare facility in University in Louisville, so we had direct access, probably one of the biggest healthcare facilities in the country. So by her working there, she had direct access, connecting with doctors, being able to, get the necessary help. But it was not enough, right? Because she grew up, she had more issues, she had more challenges that affected her growth. It ultimately affected her social development to a point where she rarely talked. I don't think she really talked until she was like 6 years old, which was, part of her seizures. So, I was, like I said, I was looking at questions popping up. And again, that's why I'm kind of, excited to talk about my niece, because growing up, watching her grow up, I would always ask my mother, say, hey, Mom, what's the matter with Mackenzie? She's like, oh, nothing, she's normal. And that's kind of the common thing, we don't want to stigmatize our children. We don't want to stigmatize individuals, letting them know that they have seizures. But I think that's the incorrect way of approaching this situation. And I'm appreciative of this webinar, that it's getting the idea, getting the information out, letting people know that, hey, having epilepsy, having seizures is totally fine. So, back to my niece, the continuous challenges that she faces, she had IEPs all through high school, all through her academic career, where it really didn't start until like her high school when she got the IEPs, individual education plans, that, created more and more issues that, such as her violent behavior. And, I'm not saying that she's very violent all the time, but as Lowell and others said, there was issues like regarding behavioral issues, and she dealt with that a lot. And we had to, seek out more help. And luckily, I have a cousin who is a neurobiologist. He's on the STEM science neurobiology, but he's able to recommend us individuals to contact and work with my niece. So that was really helpful in the sense that she got some help. She's doing a lot better. She's more vocal. She's more engaged. One of the things she loves to do is draw. And, and I'm looking at it and, working in higher education, I kind of connect two and two. And I kind of told my mother, I was like, hey, I think Mackenzie's on the spectrum. I don't know, but y'all might want to look at getting her tested out. And by speaking with Mr. Lloyd prior, I came to find out there is a direct correlation between epilepsy and seizures with being on a spectrum, which I didn't know. And I wish I knew it sooner. We would have been able to, find ways to help her grow, help her socialize, help her find out what we can do as a family and as loved ones. And, ultimately, make sure that she has, she's going to have a great life, but more productive life in a sense. And not saying she's not productive, but being more engaged in the community settings. So, like I said, as a story is short, I just appreciate organizations like this encouraging the importance of, Blacks dealing with epilepsy. Because again, there's a lot, I know there's people I've came across that have had seizures and they didn't know it, right? And the facts behind that is that it could have been prevented or it could have been taken care of with medicine, such as me. When I was young, I was on medicine for a long time till I was like 5 or 6, and then I never had another seizure and they weaned me off of it. So I was, I barely remember it, but I remember I had one, it was like a grand mal seizure. So that was quite a scary thing. But comes to find out, the backup, my sister also dealt with epilepsy and seizures. I remember hers vividly. She would just go silent and we would say, what happened? It's like her brain just shut off. And then it just rebooted it and came back, and then she was okay. But again, she was on medication for a long time until she's able to get off of it. I think it partly affected her social well-being. But again, it's one of those things that, I want to be an advocate. I'm gonna say I don't want to be, I am an advocate to encourage people to understand that seizures are very important, be aware of the signs, and not to make fun of individuals. Because again, growing up as a millennial, kids are not nice. They don't know what to say. And, when someone had a seizure, they're like, oh my gosh, coming with names. So hopefully, moving forward, we can, create this village of caring and being able to improve information, such as, Mr. Lloyd and Dr. Smart, talking with the healthcare professionals, talking with public officials, and creating ways for individuals with epilepsy and seizures to get the care that they need. But like I said, I don't want to waste all your time, but I want to open this up to discussion and questions and answers.
Thank you, Dr. Vashon.
Yes.
Yeah, I like your closing statement when you said, let's create a community. That I think is one of the biggest key to success in this work of creating awareness and improving knowledge. So thank you, all of our panelists. Thank you, all of our speakers. We are now moving to the discussion session, the Q&A. So I have a few questions already that I got from the chat. So the first is for Dr. Smart. I'm not sure if he's still on with us, but I'll just go ahead and read out the question. And if he is, okay, good. I think he's still with us. So the first question is, what detail can you share about RNS as a method to control seizure? This is for Dr. Smart.
Oh, okay. So RNS as a method to control seizures is just as useful as any medication. Typically, we use that in patients who are having trouble with medications and are not necessarily amenable to surgical resection because they may have a multiple foci epilepsy. So it's not a first choice, but if you failed two or three medications, then you should see an epileptologist to undergo an EMU evaluation to see if it is an option for you.
Okay, thank you. And then the other question is, can you recommend an epileptologist in North Carolina?
Well, I trained in North Carolina, so I'll always recommend Duke.
Okay.
Duke University has some great epileptologists, and I would actually recommend to anyone, if you have epilepsy, and especially if you're not well controlled, you should go to the academic center in your community at least once a year. Good. Because those academic epileptologists can at least get you on the proper medication or see what's possible, make sure you have the proper type of epilepsy for the medications being used, and then send you back to your neurologist who can then manage the medication. So when I was at Duke, we had people who would come from the rural part of North Carolina once a year, and they'll turn it in a trip, come and hang out at the Cheesecake Factory in the city, and we'll just see them once a year, and then we'll communicate with their neurologist back in their community. So I would recommend everybody know the closest academic epileptologist in your area and go there once a year, just to make sure everything is controlled and doing well. And then that epileptologist should communicate back with your neurologists who are closer to you.
I think they said Northern California.
Northern California, sorry. I thought it said North Carolina. But I would say the same thing. Find the academic center that's near to you, and I would go there, because usually the academic centers have specific epileptologists that all they do is take care of seizures.
I'll jump in here and just also advise that it can be a really high anxiety and bar to think, oh, I'm going to go to the academic research center. Let me tell you a little easier track. Go to epilepsy.com. There is an epilepsy specialist and a public health worker who is thinking about how to connect you to epileptologists and neurologists, right? So if you're looking for a confidential one-to-one connection, there's a 1-800 helpline, as well as local resources in your community that can also help you coach. I just want to make sure that I offer the public health lens that we want to make sure you get to the right people, but you may need to work up your confidence of having this conversation. And there was another comment that was made in the chat about the resources being primarily for children versus adults. Listen, as a public health issue, there are many more adults living with epilepsy than children. And oftentimes what we see in Minnesota is that our adults want one-to-one confidential consultation. They're not looking for a social club. Compared to addressing the social stigma associated for children, there is a need to feel like there is a normalcy to having the condition when you're under the age of 18, and that's what we've seen play out. So I want to really encourage folks to see that adults actually are predominantly, I believe, who we're serving. I know that's true in Minnesota. Nearly 80% of the people who utilize the services at the foundation are over the age of 18. However, they prioritize getting the one-to-one connection, as many of us would do if we're getting any healthcare consultation. So I also want to destigmatize the notion of not going to your Epilepsy Foundation. They just probably aren't bragging about this work that they're providing to the community and for adults.
Thank you, Glenn. Thank you, Dr. Smart, for your response. And I would take your response as a segue to a question that I had hearing you speak earlier. So what would you advise a Black man, or how would you advise a Black man who is struggling with coming to terms with the diagnosis of now having epilepsy? You know, how would you approach, you know, coming from the Black community with the stigma, with the concern of, you know, funds to care and get better care? What would be your advice to that Black man per se?
So I would take it even a step back. I would actually give an advice to Black men who have the diagnosis of a psychiatric disorder. And I would tell them all of this. One, make sure you do see a neurologist, make sure you've gotten EEGs, and make sure you've gotten MRIs to see why and what type of epilepsy you have. Because if we know what type of epilepsy you have, we can sometimes control it very easily if we pick the right medication. For example, if you have a certain primary generalized epilepsy, certain medications may be causing you more seizures than less. So one, I want to make sure with all our patients who have psychiatric disorders or concerning for epilepsy that they see a neurologist and make sure they have the correct diagnosis. Number two, what I typically recommend to a lot of my patients who don't have funding is one, the Epilepsy Foundation. And the reason why I'm willing to give this talk is I give out the Epilepsy Foundation because I used to do clinics for them. So the Epilepsy Foundations have epileptologists who sees patients, and then we help you get the medication at no cost or at minimal cost for the medication. So I would tell you, one, make sure you get the evaluation, reach out to the Epilepsy Foundation to get connected to the seizure specialist in your area that can make sure you don't die. Because, you know, seizures can kill you, especially because your heart may not always be able to stand one seizure. A lot of times we say, you know, a lot of people have one and they think it's okay, but it all depends on how much issues your heart can handle.
Thank you, sir. So the next question is for all of our panelists, and if anyone can actually speak to this. How can you help us understand the disparities in epilepsy? So this is from one of our participants. They shared that their son is on a spectrum and began having seizures. Did you all hear me, or should I go again?
I didn't hear you.
We lost you.
Oh, I'm sorry about that. So a question from the chat where one of the participants was asking if any of you could share or speak about disabilities and epilepsy. You know, just from your experience. This person mentioned that their son is on the spectrum and they began having seizures at around 12 and 13 years of age.
I can speak some because I have helped some patients with that. So as I said, some people can live completely normal lives with epilepsy. And some people have more difficulties. Now, in terms of disability, it depends, unfortunately, on how many seizures you have and repeated seizures. And the issue sometimes, as I said before, all seizures are not motor. Most seizures are actually behavioral. So a lot of times, if we don't get them under control, we can see developmental abnormalities. And we can see mental health issues. Actually, at the recent epilepsy conference, we're actually finding that a lot of people are having some subclinical seizures, meaning not causing any motor activity, that are causing behavioral or probably playing a role in their overall psychiatric diagnosis and their development. So what I say is, one, make sure you get plugged into the proper epileptologist. Number two, if you're having a lot of seizures and we can't get them under control, there are programs to apply for disability to try to get the help you may need to help you get there. And if you don't have a doctor that can help you, once again, reach out to the Epilepsy Foundation. And I would let Dr. Lloyd speak more on that, because I think I've had patients who have gone to his services that have been helped.
I'll jump in there and affirm here's the thing about epilepsy, seizures, and then disability in general. Oftentimes, patients have many comorbidities, right? If you look at some of the research, we're talking about people that have 3, 4, 5, 6, 7 different types of medical conditions happening all at one time. And epilepsy and seizures may be of their least concern. Right. So the importance is when we know folks have epilepsy and seizures in our community, we use that as an avenue to offer resources. Right. Once again, if it's your 5th diagnosis mentally, but someone knows you have seizures and they can trust that there is a public health or a community resource available who's thinking about this, I would say that that's one of the aspects that, frankly, public health, and I know community organizations are working hard on, is being able to refer to each other's organizations. So being able to link to the American Stroke Association and the American Heart Association, being able to link our work to the National Alliance on Mental Illness, NAMI, it becomes incredibly important, because our patients may be living with multiple conditions, but will seek a resource from the one that is most salient in that moment, meaning it's most personal to them in that moment. And it's our responsibility as public health professionals to be able to have the community partnerships at a local level. People always want a warm handoff. They don't just want to be connected via email. And I know Lowell knows this straight away. When there's someone's trusted in the community and can hand off with a warm introduction, it makes a world of difference of people being able to take a hold to that and move forward.
Yes, and if I may add this as well, I know one person that has seizures, but they have what you call nocturnal seizures, and they only have them at night. So they work a normal work schedule, 8 to 4, and at night they turn in, and so they can work their normal schedule, have a normal job, and go, just live life as normal. No problems at all, but they do have epilepsy.
Thank you, Mr. Lowell. I have another question for Glenn. Where do others see more of the social inequalities in a hospital setting with race? And what language has been effective in your areas to break down the social stigma in the community or at home?
So as somebody who works in the hospital, I'll start. First, I always like to tell people you can live normal with epilepsy. The Chief Justice of the Supreme Court is still the Chief Justice of the Supreme Court, and he's had seizures and has epilepsy. So that's number one. In terms of breaking down what's going on in the hospital, so a lot of it is perception, and unfortunately, the issue may start in the emergency room. And I can't blame the ER doctors, because ER doctors have these patients coming, all patients coming into them. And they have to make quick judgments of what they think is going on with these patients and where these patients are more appropriate to go. And sometimes they don't have the full armamentary of studies that I have in the hospital, such as EEGs and those things. So it's easier at times for them to fall back on or fall victim to certain stereotypes, behavioral abnormalities, concerns. For example, when I was in Miami, one of my patients who had epilepsy would always end up getting sent to the psych office. A Hispanic gentleman will always end up in the psych hospital when he came in focal seizures. And the patient didn't help himself because occasionally he did smoke some marijuana and those things. But I tried to tell the ER and leave it in his chart, when he comes in confused, before you send him to the psych hospital, call me and do an EEG. But they see him, they see the behavior, they see the perception, and they automatically think it's psychiatric. And you have the same thing, unfortunately, at times with African-American males, with African-Americans, because you come in and a lot of times physicians don't think of seizures as being behavioral. And I keep saying this because I've had one patient who for 2 years was diagnosed as psychiatric. And when we finally saw her at Duke, when she came in from one of those rural communities, she was having right temporal lobe seizures. So unfortunately, if you don't think about the possibility, when you see confused patients who may be aggressive because they're confused, it's easy to sometimes stick them with a stereotype, stick them in a psychiatric facility, or treat them as psychiatric, rather than get the full history of what may be going on to make sure you're not missing something else that may be primarily neurologic.
Thank you, Dr. Smart. I have.
Can I offer one?
Yes,
I just
go
want to
ahead.
offer one word that I found to be really normalizing. The word seizures. Listen, that's what people are having, and epilepsy can have stigma attached to it. And so one important suggestion I'd make is expand your language, because there are some neurologists and epileptologists who are only comfortable talking about seizure disorders and not epilepsy. And so we need to stop, frankly, in my opinion, trying to raise the conversation and get committed to talking about it, how people talk about their seizures. And so I'd invite us to use the word seizure more. Talk about seizures, normalize that language in our public health approaches, in our community conversations, because when you say seizure, it has a very distinct definition of people, but often that is the point where I see people really open up to the conversation, compared to trying to convince people that epilepsy is the conversation. We've just become more inclusive to terms that we see community using. And often we see people who don't utilize our services being afraid of the word epilepsy, but much more interested in talking about their seizures. It's a hard reality that plays out, but I think until we're at a time when epilepsy is destigmatized, we should be thinking about the more inclusive language of seizures for our communities.
Thank you so much, Glenn. That's very, very important that you brought this point up, where people are comfortable just focusing on seizures, but the real conversation should be, taking it to the next level where we talk about epilepsy, because that's what now brings in the stigma and the, negativities. Thank you so much for that. I would now ask 2 more questions, but the first one is to the panelists, and then the last one is for Mr. Evans. As we focus on Black men living with epilepsy today, we know that interactions with law enforcement has been a factor of consideration. How and why should law enforcement be a targeted audience of increased epilepsy knowledge and awareness?
Oh, I'll jump into this because I've actually had this issue too. So now, I'm a philosopher at heart, so it always gets me to this existential question of who we are. And let me explain what I mean. When you have a seizure, especially in the temporal lobe, or even what we call the orbital frontal lobe, the executive part of your brain, afterwards, you're confused. And you can be aggressive because you have no idea of what's going on around you. And I would never forget, it made me sad because this mother called me. She called the police because her son had a seizure and he was getting combative and confused. And she was sad because she called the police because she couldn't control his behavior after the seizure, and the police was tasing him. And she's saying this is going to make everything worse. And she had me on the phone, and I'm trying to explain to the police, don't tase him because he's seizing. So there is this whole confusion around this. And I don't know how you explain it, because it's even a problem sometimes with non-neurologist physicians to understand that, once again, seizures are more than just motor. And afterwards, the patient may be even more confused. I've had a small lady, probably no taller than 5 feet, weighing probably no more than 100 and something pounds. And it took 5 of us to control her after her seizures, because she was completely disinhibited. And she just thought we were all after her. And we had to try to get some medication in her to calm her down. So it is one of those things that is hard. It is very hard. And it scares me sometimes, because the police are not known to be understanding when somebody's not communicating. Right. Because, for example, I forgot which activist in California, after a car accident, was on the ground, walking around, seemed confused. And in my head, I started wondering, one, post-concussion or seizures, and he ended up getting shot.
Wow.
So it's a hard thing, and it'll take a lot of work.
Thank you, Dr. Smart. Yeah, it's no doubt a confusing situation. And I think as we have this type of webinar and conversations like this, it's also important to maybe begin to cast a wider net and increase our reach to the law enforcement community, to perhaps take the seizure first aid course, increase their awareness, make them more comfortable, help them know more about epilepsy and seizures.
One thing I would add,
One
thing I would add a point. What I've told my patients, especially the ones who I know get aggressive and behavioral after their seizures, wear the epilepsy bracelets.
Yes.
Because it at least gives somebody the idea that there's something maybe medically wrong with you. Because people don't know. I mean, I've had somebody who people have stolen their stuff on the bus, but somebody helped them after they saw the bracelet on their hand. So whenever you have epilepsy and you know you have confusion or behavioral changes afterwards, maybe even not, wear the bracelets, because that at least may give somebody some pause if they see that.
And increase our commitment to partnership, right? It's not just that we need law enforcement to have seizure first aid training. That's a must for every person, as Lowell would say, with the brain. Right. We need to partner and build really training, enforcement, certified units into their professional development. That only happens because we go first interested in partnership. That's what has proven to stand the test of time. Is community partnerships doesn't mean that we have all the expertise. People know what they see on the streets and what they experience. We need to be advocates of bringing a conversation to write curriculum together to make sure we address and that we hear the voices of people who have been arrested, handcuffed, been targeted by police while having a medical condition. So very much so, I just want to make sure that we make the point. It is the invitation for community partnership, actually, that goes deeper as a policy advocate. That's what I have to say, is we have to keep creating spaces where folks own the work themselves and we're seen as a partner, not just an educator talking out into thin air.
Thank you so much. So I'll ask the last question. This is for Mr. Evans. What is the biggest barrier that you had to face or navigate after you got your diagnosis as a Black man?
Okay, well, let me just put it this way to you, because everyone has the groundwork there. A few years back, I got arrested. I'll be honest with you, I didn't have my bracelet on, but I did have my driver's license. I felt an aura come on. I pulled off the side of the road and I passed out. I was parked evenly within the parking space. And when I came to, I was in the back of a police car headed toward the police station. I woke up, I told the police officer that I probably had a seizure and that's why I was sleeping. He paid no attention to me. I got into the headquarters. I told his boss that I probably had a seizure, and he asked the arresting officer. He says, "Did you give him the breathalyzer?" He says he wouldn't talk to me. I said, "Sir, I couldn't talk." I said I was having a seizure. He said, "Well, he wasn't on the ground shaking and having convulsions." I said, "Sir, that's another type of seizure. I don't have that type of seizure." He said, "Well, did you give him the sobriety test?" He said, "Sir, he wouldn't listen to me." I said, "Sir, I couldn't listen. I couldn't hear you. I was out of it." And then when the head police officer, his commanding officer, finally realized that I wasn't upset, I was talking clearly. He knew I had not been drinking or anything. He realized that I had a chance right there to really, bring the hammer down and probably file a lawsuit or whatever else, for them. But I said, "Look," I said, "there's a misunderstanding here." I said, "Let's just let this go. I won't touch it." I said, "We need to talk again soon." And I said that he doesn't understand epilepsy. I said, "I just need to call my brothers to pick me up so I can, turn my license in." When I said, he said, turn your license in. I said, "Yeah." I said, "I just had a seizure. I can't drive anymore." They did not even know that. In Virginia, you have to go 6 months without a seizure. Now, that was a few years ago. Now I'm working with the police officers in the state of Virginia and also the FBI. I'm attending meetings with them to educate them about epilepsy. Now, it's on YouTube. If you look on the Lowell Evans and the police and the city police, you'll see the discussion about epilepsy being arrested, where I was arrested. So it's very important that we make contact with them, just like all the panelists have talked about, because we have to educate them. One person almost got shot, and I believe it was in California or Maryland, where they turned around because they had a seizure, and they turned around, and police officer thought that he had a gun in his hand. And thank God he didn't put a trigger to that gun.
Wow, yeah. I mean, I've heard stories, but that's a wow. But you're doing good work with the police, because I think it is something that's needed. I think Dr. Lord is right. There has to be some kind of partnership and education. But also, I think it's a bigger issue with the police in our society, right? They're not the ones who should be dealing with all of these calls, right? And, I have to defend them in some ways, because that's not what they're trained to do. But unfortunately, we use them for everything in our society, and they can't deal with this. Because every time I've had a patient interact with them, it has never gone well.
That's true. That's true. But see, I was stopped. I had already been stopped. I couldn't. He should have called the ambulance or someone, because I couldn't do anything. He should have took me to the hospital or something.
You're completely correct. And that's what I mean, that when we talk about implicit bias, right? His first thought process wasn't that something was wrong with you, but rather that you were doing something wrong.
Right. Something about drugs or intoxicated. That was his first thought,
Well, everyone, I have to run.
Thank you.
This was a great talk, and I look forward to doing more.
Thank you, Dr. Smart. Thank you, everyone. Thank you, all of our panelists. Thank you, all our participants. We've actually come to the end of this. I mean, we could go on and on. As you all can see, this is a very, very interesting and thought-provoking conversation, where we can have very good conversation about epilepsy, seizure, stigma in Black men, in Black communities, and see how we can move forward. But I would like to thank you all, and also invite everyone who participated to take our seizure first aid certification course. We have a couple lined up till May. The first is in March 7th in Spanish. Another one is in April, which will go along with the National Public Health Week in Spanish. We also have it in English as well. So it's not just in Spanish. We have both in Spanish and in English. But we have all these courses lined up. And there is a chess credit and a 2-year certification for anyone who takes it. If you haven't done so, please endeavor to do so. So as we wrap up, I want to thank you all, our panelists, once again. I want to thank the host of this webinar, the program, the multicultural program at the Epilepsy Foundation. I want to thank all of our participants. All of your chats, made this very lively. And also, wish everyone a wonderful week ahead and look forward to seeing you in the nearest future. Thank you.